Good morning. Thank you for joining us for the webinar ENT Emergencies for the Rural GP. This webinar forms part of the Rural Health West 2020 virtual conference. Before I hand you over to your presenter, I'd like to run through some brief housekeeping. If your audio is not coming through too clearly, you may prefer to switch through to your phone. These numbers will be listed on your dashboard. Remember to enter the PIN number 2. Everybody has been placed on mute to minimise background noise, but we would still love to hear from you. If you have any questions for Sarah during the presentation, please enter them into the question part of your dashboard, and these will be answered at the end of the presentation. This session will be recorded and uploaded to the Rural Health West website under the virtual conference banner. I'll now hand you over to your presenter, Dr Sarah Grigg.
Hi, welcome everyone. My name's Sarah. I'm an ENT trainee in WA. I'm just putting my screen up there now, if you can see that. What I've been asked to do today is talk about ENT emergencies for the rural GP. And I've thought of a couple of topics that I think might be relevant for those who might be not within close distance to a local hospital, or indeed for any GP working in the community as well. A little bit about me. I'm a trainee in WA. I've actually grown up in Queensland and worked both in Victoria and Tasmania as well. But I must say that WA takes the cake for the definition of rural medicine, I would say. So there's a couple of topics that I've included today, including sinusitis, otitis externa, epistaxis, foreign bodies in ENT, as well as the presentation of sore throat. So sinusitis is obviously a very common presentation both to general practitioners as well as to ENT clinics. And basically, I just thought I'd touch on the definitions, being acute, less than 3 weeks, chronic, greater than 3 months, and that's with symptoms more than 4 out of 7 days for which they have symptoms. And then recurrent sinusitis is obviously relapsing acute episodes. There's many causes of sinusitis, and they include anatomical obstruction, and I've listed a few common things there. Obviously, these were things that you would most likely see on a CT scan, but clinically, you can obviously see a septal deviation and turbinate hypertrophy. Allergy is a common cause, as well as nasal polyps, and they can have coexisting infection. Patients will often present with the sinus problem, and certainly that's a very common presenting symptom, which doesn't tell you very much, obviously, but mainly it will be nasal discharge, obstruction, pressure or fullness in the face, pain and headaches. There's a couple of sort of tips that I would suggest in terms of looking and examining the nose. So obviously looking to see if they have purulent secretions, and that can be on anterior rhinoscopy, and obviously a light up the nose, either using an otoscope or a camping headlight. And if you have access to Vaticums, they can obviously help to spread the nostril tissue so you can get a better view. I always look for postnasal drip in the back of the throat, and you can often see that with a tongue depressor and then streaking the posterior pharyngeal wall. Turbinate inflammation from the side wall of the nose is very common, and then nasal polyps. So they have a green grape-like appearance within the nasal cavity, and they often are either poking out the nose or will sit a little bit distal and posterior to the inferior turbinate. So often there'll be 3 structures that you can see when you look in the nose, and I've got a picture to demonstrate that. Nasal polyps can be red if they're acutely infected, but otherwise do have that sort of grassy, green-like appearance and look like a grape, actually. Obviously, facial tenderness along with percussion is a useful clinical feature as well. Here's a good picture taken from a recent NEDGM review of sinusitis, and obviously we have a picture of a polyp adjacent to the inferior turbinate and the septum, and that can be viewed through anterior rhinoscopy, and they've demonstrated how you could see that using a light shone up the nose as well. And it's important to note the difference of the mucosa of the septum and the turbinate compared to the polyp. Often a turbinate can give a subtle appearance of a polyp. What is useful in that instance is to palpate the turbinate, and if there is bone underneath that you can feel by using even just a long cotton tip, then that would obviously be more consistent with a turbinate than a polyp, which would be soft and squishy. So that's an important thing to sort of see when you're looking up the nose. Radiology, obviously in the acute setting, can be very useful, and that would most likely be a CT scan. Occasionally MRI scans would be ordered, but that can be in discussion with your local ENT, and that would be more if there were complicating factors of sinusitis like periorbital cellulitis, which can occur in children. But CT is very useful also to demonstrate chronicity as well. Now we talk about sort of some treatment, and this is my stepwise progression on how I treat sinus patients who I both see acutely in clinic or who I get called for advice on. The most important management for sinus disease is the nasal douching, and what that does is it helps to clear secretions that might be blocking the drainage pathways of the sinus, and also to improve normal flow of mucus within the nose. There's lots of preparations of normal saline sprays and douches, whichever brand you have available, and there's also a few personal recipes that you can provide to patients if they cannot afford to keep using the flow rinses. Inhalations, for symptom relief, they can use things like Vicks and hot water. That also can give them some temporary relief. Antibiotics, steroids, analgesia, and decongestants. They're also things that should be used in these patients. Antibiotics if they have evidence of bacterial infection, such as green purulent or bloody discharge. Steroids is something that ENT surgeons use routinely, as we find that that helps with the mucosal inflammation around the drainage pathways of the sinus. And I also would use a short course of a nasal decongestant, such as Otitis, but no longer than 72 hours. Again, that helps to improve the sinus drainage pathways. I don't need to tell you, obviously, what we're looking to cover. Things like Haemophilus, strep, varicella, and staph, particularly in chronic cases, will be more likely. Commonly used antibiotics, obviously, therapeutic guidelines provides quite a few stepwise progressions. Things like Rulide and Bactrim, you can use Keflex and Flagyl. I also quite like Augmentin Duofort. And if I'm being called about a patient who has failed an initial course of oral antibiotics, then often we discuss about a longer course of doxycycline, which is well tolerated by most patients. Nasal steroids, as we discussed, you can mix that up with also a fast saline spray as well to minimise epistaxis. That's a common sort of presenting complication of nasal steroids, and obviously the timing of the dose, both morning and night. If your patients are concerned about intranasal corticosteroids and the dosing of steroids, you can reassure them that it would take 1,000 sprays of Nasonex to be equivalent to a 50 milligram dose of prednisolone. We would ask that you trial patients on Nasonex for at least 3 months, up to 3 months, as that gives you the true effect. Unfortunately, it won't work just for a week or two, which a lot of the patients will use and then stop. Oral steroids, as I mentioned, we would routinely use prednisolone, 50 milligrams for approximately 5 days. Therapeutic guidelines suggest that you do that with specialist advice, and obviously I'm happy to get calls from rural GPs about when to use oral steroids. Then moving on to otitis externa, which is something we see a lot of in WA, particularly with all of our water-based activities. It's obviously an infective inflammatory disorder of the external auditory canal. Occurs about 4 per 1,000 people per year, and obviously majority in summer with water exposure, although Perth has a lot of summer all year round. Risk factors include anatomical obstructions, particularly exostoses, which of course is related to cold water swimming and bony overgrowth in the ear canal. Also, if they use hearing aids, self-induced ear trauma, and that's to imply people who use cotton tips in their ears, swimming and water trapping as well. Organisms, obviously, quite commonly it's Pseudomonas, which has a characteristic odour and a yellow-green colour, and then staphs make up the other proportion. There is a small proportion which will be made up by fungal as well, which we'll touch on. Obviously the cause of the infection is if the hydrophobic coating of the external auditory canal is breached, and then you have an ability for the bacteria to reach in underneath the epithelium, and that can cause the infection that way. Most fungal infections, however, are opportunistic and likely to be secondary infections. Commonly, if ciprofloxacin and eardrops have been used for more than 2 weeks, then that's certainly a risk of a fungal overgrowth, and certainly we do see a lot of that. Obviously, they'll be giving you a pretty good history of a otitis externa. That's pain, itching, oral fullness, reduced hearing due to the narrowing of the external auditory canal, and discharge from the ear as well. There's a few good ways to consider what the diagnosis might be actually by the appearance on the examination. So obviously you'd be looking for the erythema and the edema of the external auditory canal. If they have what appears to be a furuncle, then that's common with a staph or a Pseudomonas infection, and obviously this can help you target your antibiotic therapy. A white debris is most likely to be Candida. If the debris has the appearance of wet newspaper, then that's most commonly Aspergillus. A maculopapular eruption is common with Staph aureus or an allergic dermatitis. And then if you're getting quite significant erythema and thickening of the conchal bowl and the meatal skin as well, then I'd be looking to consider an allergic reaction or a contact dermatitis as well. Granulation tissue can be indicative of a fungal otitis externa, as well as the body thickens the epithelium in order to try and provide a barrier. I've just got a little picture here of a characteristic sort of pseudomonal infection with the slough and the debris. And you can see the slight edema of the meatus as well, with that rippling and dimpling effect externally. Again, on the left, it's a very characteristic furuncle, and if you palpate that, often you can express pus through that area as well, which can help to obviously relieve the infection, and that can be causing quite significant pain in a tight circumferential area. Aspergillus on the right there, and again, I think it does have that characteristic wet newspaper appearance, and when it is removed, it comes out looking like sheets. It's not sort of something that gets easily sucked up in a microsuction or on a tissue sphere, but it is sheets of debris. First management should be removing the precipitating cause. I suggest obviously dry ear precautions for both ears. I like to remove ear piercings. A lot of people have tragal piercings and conchal bowl piercings, and unless they're using so alcohol wipes routinely to keep them clean, then they can act as a fomite for a source of infection ongoing. They should also avoid using cotton buds and itching the ear, as often most skin bugs are found underneath the nails. Either suction or tissue spears to clear the discharge. Obviously, if you don't have access to a microscope and microsuction, then tissue spears are certainly a very effective way in order to clear discharge, and that would be something that you would do until the tissue spear is clear, and then the patients can do themselves twice a day at home. If you did have access to an otowick and the canal was quite edematous, then that would be useful to place as well, and that would last anywhere from 48 to 96 hours. Or alternatively, if you don't have access to otowick, and certainly I've worked in hospitals where we haven't, and I have instead used, you can use 1.25 centimetre ribbon gauze, and I would coat that with some Kennicomb, and I've written place, but equally it's a force into the ear canal. It's unlikely that you can go deep enough to cause any damage, and really that will help to open up that meatal skin so that the drops can get in. Obviously, if you don't have Kennicomb in stock, I've on many occasions given the script to the patient to get filled, and then they've returned to have it placed. It likely falls out in about 2 days' time. And then obviously the mainstay of otitis externa is ear drops, and I find that there can be a lot of sort of confusion sometimes about which ear drops to use first, and so I've created a bit of a table which both I use for reference, and then obviously when I get called for advice as well about what to use when, and particularly which drops are safe in a tympanic membrane perforation. Often I will acknowledge you can't see the tympanic membrane when dealing with a patient with otitis externa, so it really would then depend on the history and whether they've had any previous perforations or a known history or known ear surgery. And within reason, if they don't have any of those things, then you could assume the tympanic membrane is intact. So I've listed them down by the side, and certainly we can talk about this at the end, but in the first instance, I would mainly be using Siloxane or Ciproxan HC, depending on the amount of edema of the ear canal. Obviously, I see a lot of the Pseudomonas infections in the ENT clinic. Siloxane is the one that is safest with a tympanic membrane perforation. I've listed that ciprofloxacin 8C can be discussed with specialist advice, and there are some special circumstances that we can use that if there is a tympanic membrane perforation. But again, I would encourage you to call for advice on that one. Certainly Sofradex has its role, as well as it has dexamethasone, so they're quite good for infections that you think might be more of a staph infection and that have edema of the ear canal as well. The two fungal ones at the bottom, certainly Leukocortin, there's been issues with supply over the last 12 months in Australia. So if you can get it, it works very well for the fungal ear infections. And if you can't, then clotrimazole 10% lotion, which most compounding pharmacies have access to, can also be used, and it's just placed in a dropper. And then you use about 3 drops twice a day in order to clear that infection, and that works quite well as well. So just briefly touching on fungal otitis externa, and obviously there's two scenarios. One is with an intact tympanic membrane, and obviously strictly using water precautions is most important. Microsuction or tissue spheres if you're able to, the antifungal drops as I discussed. And then I would suggest that post-completion of the treatment course and then reassessing the patient to see that the fungal infection has cleared, that you would consider a drying agent such as aqua ear, and that ensures the acidic environment in order to prevent the fungus from returning. It's quite common that fungal otitis externa becomes a chronic process, and patients can cycle through many courses of these infections because they never get the correct biochemical environment back into the ear canal in order to ensure that the fungal overgrowth doesn't pop up again. Boric acid is also something that can be prescribed as well, and that's available at compounding pharmacies, obviously a very historical drying agent, and obviously a referral to ENT if it fails to resolve or you feel like there's deep debris in the ear canal. Obviously with a perforated tympanic membrane it becomes a little bit trickier, as the antifungal drops can be considered ototoxic. I would suggest strict water precautions, microsuction, and then obviously an earlier referral to ENT if it fails to resolve the suction. Obviously there's several complications of otitis externa that can occur. You can then have involving cellulitis, and I think it's important to note whether it is cartilage sparing or cartilage involving, because flucloxacillin does not have very good cartilage penetration due to its poor blood supply. In those cases of perichondritis, you'd be looking to see whether the earlobe skin is involved or not, as obviously there's no cartilage within the earlobe. In episodes of cartilage involving, I would be using ciprofloxacin orally, and then also warning them about the risks of Achilles tendon rupture, which of course is incredibly rare, but is certainly something to caution patients with. You can get tympanic membrane perforation, medial canal fibrosis from thickening and scar of the chronic infection. And then I just wanted to lightly touch on malignant otitis externa, which we certainly are seeing a lot of as people are getting older and are in more of an immunosuppressed state, including diabetes. And that would be really a patient who presents with ongoing pain despite the normal course of treatment, and perhaps that's pain out of proportion to their clinical picture. And they characteristically present with a granulation tissue or polyp in the ear canal, or often exposed bone in the floor of the canal. Often they can also present with cranial nerve palsies as well. So this would be the elderly patient who you've treated for 3 or 4 weeks, perhaps with different courses of topical drops and oral antibiotics, and it does not appear to be getting better. And they obviously have increasing pain as well. Those are the ones that you could have a low suspicion for organising a CT scan of their temporal bones and then discussing with ENT. I should note, however, that the bony changes on a CT scan often can present quite late. So if you're worried, we'd be more than happy to see them in the clinic if it's been going on for more than 4 weeks. Here is just a picture of a granulation polyp in the floor of an external auditory canal, and that's something you would see in malignant otitis externa. Next, we'll move on to Epistaxis, which is a common emergency presentation both to GPs and to rural emergency departments as well. Pardon me. I don't need to touch on too much about what causes nosebleeds, but certainly they can be local or systemic, and they can be due to changes in the nasal septum, mucosal injury, including nose picking, which is a very common one, and malignancy. Certainly some things that we see quite a lot of as well are the systemic causes. A lot of patients are on anticoagulants these days, and a lot of patients suffer from hypertension and excess alcohol abuse. In fact, over the weekend, I had a patient who had all three who presented with a nosebleed. Most bleeds can be visualised anteriorly, and indeed 90% of bleeds will be an anterior bleed, and that's all taken from the history of how the bleeding first presented. There's just a brief diagram about the confluence of vessels at the anterior septum, in that they're all quite interlinked, but also very close to the surface, which is why they're an obvious source. It gets both supply from the external and internal carotid artery as well. And then about 10% of bleeds will be posterior. Obviously on evaluation, you're looking to take a history, but primarily ensuring that their ABC is patent. Often I would take the history, but after placing some cofenolcane soaked cotton balls up the nose in order to try and see what sort of vasoconstrictive effect that can have. I've just touched on a few little things that are certainly sometimes missed in the first evaluation of a patient with epistaxis. Certainly herbal medications, including fish oil, is something that's still relevant. Cocaine in the younger patient does happen more often than you would think. And then home CPAP as well. Certainly I get a lot of elderly patients, and although it sounds like they've got no precipitants for epistaxis, they are using a home CPAP machine without a lot of humidification, and that is a very common cause. And then rhinitis. A lot of patients will be using their sprays excessively, and as we touched on earlier, that can obviously dry out the nasal mucosa and result in epistaxis as well. This is, for examination, I guess, depending on the resources that you have in your clinic, or whether you work in a local ED as well. And I would also start with the patient sitting up with the body tilted forward to allow the blood to be spat out so they're not swallowing it. Obviously, that will make them feel quite nauseated, and that can result in vomiting. I always say that there has to be continuous pressure to the nasal alar for several minutes. I say 10 minutes. It takes 7 minutes for blood to clot, and no one can count to 7. And no peaking. So the minute obviously pressure is released from the nose, the clot will dislodge, and you'll have to start again. Cofenolcane if you have access to it. And ENT is really just about adequate lighting. It's small dark holes. We can't necessarily see anything more than you can, but obviously we have headlights and good lighting. So that can really be to your benefit, and camping headlights work just as well. If you can obviously localise for active bleeding, then that's really quite important to try and see if you can see it anteriorly, and always be examining the back of the mouth as well to make sure they don't have a large clot sitting at their oropharynx, which can be at risk of an airway compromise if that clot is aspirated. Obviously, if you're unable to control or pack the nose, then you're referring in for further specialist advice or care. This is just a little flow diagram that I've created for a lot of the EDs that I've worked in, and certainly something that can be quite useful. And a lot of the time it's about simultaneous management, and what that can help to do is both manage their systemic factors as well as their local factors as well. And blood pressure certainly is the most common associated symptom, whether that's because of the fact that so much is happening for the patient and their blood pressure is going up, or whether that is actually the cause of the epistaxis. So certainly managing that is quite a useful adjunct. Obviously, it's all about whether you're trying to see if it's an anterior bleed or a posterior bleed, and that will help to dictate what sort of nasal packing, if required, you will need. As I said, most epistaxis is anterior, and that would be suited to an anterior rapid rhino if you have that available. And then obviously a posterior pack would be used if you're concerned that the bleeding is coming posteriorly. And obviously if bleeding is persisting despite this packing, then you're discussing that with your local specialist and then considering further management as well. This is just a little bit of an adjunct. I'm not saying that this is sort of necessarily something you would have like platelets in a GP clinic, but it's certainly, something if you are working as a GP in a local ED to be useful. But at the end of the day, if there's any concerns, then, ENT are happy to accept these patients for management. touching on cauterization, certainly in the GP clinic, if you have silver nitrate sticks available, can work quite well. And I would be suggesting that for minor bleeding, and whether you can see the bleeding point very easily on anterior view. It causes minimal tissue damage, and if we can avoid packing patients, that is ultimately the ideal outcome. They're very uncomfortable, they can be often painful, result in infections, and really can make it hard to see where the initial bleeding site was, because it creates so much pack trauma within the nose. There are a few things to be cautious of when cauterizing, and that it really only works for superficial vessels, and there can be some rebleeding. And obviously what you want to avoid is cauterizing on both sides of the septum at the same level, as that can result in a risk of perichondral exposure, which can strip the blood supply and result in a perforation with overly enthusiastic silver nitrate cautery. I always have a very strict protocol for my patients after cauterizing them, either in clinic or in the emergency department. And I say they can't have any hot food or drinks, and that includes hot showers as well for 5 days. Obviously, you don't want any vasodilation of the greater palatine vessels or the vessels within the nose. So they have to have cold tea or tepid tea for 5 days, which they don't particularly like. I also suggest no nose blowing, sneezing or heavy lifting for 5 days as well. Very strict nasal hygiene, so that includes nose oil and fess, and I would use that twice a day for 1 to 2 weeks, depending on the extent of the cautery. Obviously, if you can remove or manage the precipitating cause, that is add humidification to their CPAP machine, clarify their anticoagulation status, or obviously educate them about avoiding digital trauma. That's very important. And if you have done a large area of cautery, then I would often apply Kennicomb to the area afterwards in order to create a sort of a very moist environment, in order so that that scab doesn't become too dry and then fall off and they bleed again, which certainly can happen. Pawpaw ointment works just as well up the nose as well. Now I thought I would touch on foreign bodies, as that's certainly something particularly in the paediatric population that will present. For my point, the preparation is key, and certainly your best shot is your first shot. So I would have all equipment available. Often you know straight away from the parents that there is a foreign body, and really your assessment of the child should be in preparation to be removing it at the same time. Children are pretty smart, and they figure out who the person coming towards them and what they're going to be doing. And so if you've already examined them once and they're distressed, then the second time you come back to remove it, they'll already have a pre-existing notion about what's happening. So I like to swaddle all my children, and that is based on both, there's swaddling studies that have shown that it reduces the startle effect, and obviously it helps to minimize thrashing limbs as well. So I would get them to be lying on a bed or in the parent's lap. If they're lying on the bed, then I have them swaddled with the sheet. I have a nurse holding the head, as you can see in the picture below. And then often I have the parent sort of lying almost on the patient's or the child's chest, so that they can make eye contact and be looking at the child throughout the procedure. I always ask the parents to talk to them about bribery, and a 3-year-old likes nothing more than thinking about the Freddo frog that they're going to be getting if they get this bead out of their ear. And obviously light is the most important thing. So allowing you to have hands-free, which would be either a headlight or a handheld light held by someone else. So in terms of for ear foreign bodies, what we'd be looking at here is it's all about the right equipment for the right job. And I do bear in mind that you may not have all of these different types of equipment at every practice that you would work at. But irrigation, for example, I would really only use that for insects or really loose, small objects. And certainly listed on the side there, nothing to do with batteries, vegetable material, which can swell with water, obviously. If they have grommets or again foam balls, will swell as well. And I've certainly seen that happen. Alligator forceps, and I've got a picture on the next page of what that would be useful for is insects. If you've got a leading wing, for example, or soft graspable items, you really have to have a small leading edge for these forceps to work. If it's a round object, all you'll end up doing is just pushing it further into the ear canal. A right angle hook is certainly the number one object, or sorry, a piece of equipment that I would use to remove objects. Most of the time it's small little round objects that don't have a leading edge that children like to put in their ears, like corn kernels or beads in particular. And what you can do is you place the instrument behind with the right angle hook, and then you pull it out that way. You're never going to be able to grab that with forceps or tweezers. If it's very friable, it won't work very well. And obviously if it's very deep in the ear canal and you can't properly visualize it, then that would be a contraindication. A wax loop or curette, which is a small fine instrument with a small circle on the end of it, is useful for removing wax and very sort of small round objects as well, if you can hook them out. Here's a picture of some alligator forceps. As you can see, they've got a bayonet handle, so that when you're looking down the instrument, your wrist is lower than the line of sight. Obviously, most other forceps are straight, and when you're trying to use those, you'll always be sort of competing with your own vision, and that will be a real struggle. So if you did have access to alligator forceps, I would highly recommend using those. This is just a bit of a breakdown about what to follow through in terms of when a patient presents and what to use. And really, if you're looking at one failed attempt or evidence of trauma, then I'm happy for that patient to be referred, just because from a paediatric population, the more attempts that have been made, the more difficult it becomes, because the child really gets distressed by the procedure. If we can try and do it without requiring a general anaesthetic, obviously that's best, but often that might be the next step, and that's something that we can facilitate obviously as well. Again, this is just a little picture of different hearing aid tips that can be lodged in, these are in adults' ears most commonly, and just to show how the different instrument can be used, that if an alligator forceps was used for the first picture or the top picture, it often might just be wedged further into the ear canal, whereas you've got a nice leading edge that you can place the two prongs of their forceps into at the bottom, and that would be easily removed with the alligator forceps, whereas I would use a right angled hook for the top picture. So I guess when to refer, and that's really based on the anatomy and I guess the patient as well. So if the foreign body is closer to the tympanic membrane, then evidence has shown that it's far less likely to be removed with direct visualization, and you would be needing a microscope. So as you can see here on that picture, the ear canal narrows at the bony cartilaginous junction, so structures that get stuck there, you might struggle to get behind with direct visualization. And obviously if there's been multiple attempts and the foreign body is still there. In terms of nasal foreign bodies, again, this will be a presentation to yourselves, and it's commonly the right nostril, as right-handed children favour that side. And there's a few common sites. It's either on the floor, between the inferior turbinate and the septum, or a bit higher up against the middle turbinate. Again, it requires a compliant patient, even more so because you could consider the nasal foreign body part of the airway. I often have the child sitting on the patient's lap with the head tilted back slightly, and I would always use a nasal decongestant to improve visualization and suction the secretions if I thought there was quite a lot of them as well. Obviously, cofenolcaine doesn't have the nicest taste. Some hospitals or clinics might have phenylephrine, which is an inert decongestant that doesn't have the same taste, but that isn't always available. So cofenolcaine, just one spray is enough for a child. Again, this is a picture just of a common site of locations for foreign bodies and where to sort of look for them, particularly in children because of the height of their larynx, and they can sit in the vallecula or just behind the soft palate as well. I've had patients lose chewing gum up there and all various sorts of things as well. So again, another breakdown of what type of object it might be and then the best tool for the job. So obviously irrigation, we wouldn't suggest that given that it is the nasal cavity is part of the airway. Certainly if you've got a small bead or stone, then again using that curved hook to get behind the object and then bring it forward. Alligator forceps can be used for foam or earplugs, as you can get often some reasonable traction on that. Suction catheter could be used for smaller, soft foreign bodies such as paper. And mother's kiss, which obviously gets talked about quite a lot, and that would be used for a completely occlusive foreign body. If you've not seen or used that one before, it's when you often get the parent to both block the contralateral nostril of the child and then completely cover their mouth over the child's mouth and then forcibly push air through the nasal cavity in order to expel the foreign object. I've never used it. I guess I've always used my headlight and another instrument, but certainly it works best if it's a completely occlusive foreign body because all that force behind can then generate in that cavity. I thought I'd just touch lightly on throat or oropharyngeal foreign bodies. Most of the time these would be presenting to the emergency department, but if you're working in a rural or regional centre, then that might be your place of work. They're obviously a medical emergency and they're presenting with signs of respiratory distress. The ones to look out for are the partial occlusions, and then those are the children who present with a new cough or voice change. And certainly if there's no good history taken of a foreign body, or if it was not witnessed, it is often mistaken for croup, which obviously won't respond to standard croup management. And the history of a choking episode is very important to elucidate, or what kind of environment they were in when it occurred. They're very obviously difficult to visualise in the general practice unless it's in the oral cavity, and then obviously refer immediately for specialist review. Esophageal foreign bodies, again, to lightly touch on, they're quite common in small children who discover the dexterity of their hands and then what they put in their mouth, and coins particularly obstruct at the level of cricopharyngeus. Children can't swallow at all, so they'll have drooling and lots of saliva welling in their mouth. And in those cases, you'd be looking for an urgent AP and lateral chest X-ray. And you're really looking to make sure that it's not a button battery. And one way to distinguish is obviously based on the history, but also whether there is what they call the halo sign. And what that is you can see that there's a small area of radiolucency in the round structure, which is indicative of a button battery on the left here. And then on the right, you have what looks like a coin as well. The pathology of a button battery against the esophageal mucosa is it sets up a charge between the battery and the mucosa. So in those circumstances, obviously it's required for a prompt referral to specialist care. And in the meantime, as that patient is being transferred, then studies have shown that ingestion of honey can help to neutralise the alkalinity of that electrical charge that is occurring in the esophagus and causing the caustic erosion. So honey in any form is what we would recommend. And then I just thought I'd touch lightly on sore throat at the end. Obviously there's many emergencies that can occur from a sore throat, but just the common ones first. So look, tonsillitis obviously is a very common presentation. 70% of the time is viral and can include Epstein-Barr virus, which is very characteristic of large bilateral cervical lymphadenopathy, fatigue and malaise. And then only about a third of cases are going to be bacterial. And they're either group A strep, other forms of strep, mycoplasma, and then depending on your population and the age of your patient, you can consider things like chlamydia and gonorrhea as well. With recurrent tonsillitis, that's normally caused by, again, the staph and streps with some anaerobes in as well. The actinomyces as well can cause that sort of really protracted tonsillitis as well. Obviously, supportive care in the viral cases in the first instance. If you're considering that it could be Epstein-Barr virus with quite significant tonsil hypertrophy, then using some oral steroids will definitely help with the patient's symptoms. Antibiotics, obviously depending on your local area, and suggestions from therapeutic guidelines. And then I just thought I'd touch on lightly when to refer for tonsillectomy. So in 1984, the Paradise paper, which is the sort of landmark paper that we use for our consideration of tonsillectomy in patients, is really looking at the number of episodes per year. So we're looking at either seven episodes a year for 1 year, 5 episodes a year for 2 years, or 3 episodes a year for 3 years. That looked at the number needed to treat in order to reduce both the long-term and short-term effects of recurrent tonsillitis. And I would always counsel patients that when I take their tonsils out, they will still have 1 to 2 sore throats a year. So if they're only getting 1 to 2 sore throats, aka 1 to 2 episodes of tonsillitis a year, then I'm not really going to make a difference for them. Touching on the complications of tonsillitis, which would be quinsy, that would be certainly one that would be referred in quite commonly, and it's likely to have developed from either a suppurative tonsillitis or an infection of Weber's gland, which is a piece of salivary tissue that sits behind the tonsil and the constrictor muscle. It's quite hard to take photos of a patient's mouth, so this is just a stylized drawing of a quinsy, and obviously it's a triad of symptoms. So they have trismus, uvular deviation, and in this picture you can see how the actual axis of the uvula is deviated as opposed to just being pushed across by perhaps a large tonsil. They'll also have palate asymmetry on the ipsilateral side. And another rule that I sort of use to see if I think that it will be a quinsy or not is whether I can see the base of that tonsil, that inferior pole. If you can still see the base of that tonsil, then it might be less likely to be a quinsy in my experience. So that's really what I thought I would touch on today. I'm very happy to take any questions from either clinical practice or moving forward, or anything else that you might have had a burning desire to talk to me about. And thank you very much for your time today.